Hello and welcome to the Foundation Medicine Medical Education Series. Today we have a very exciting topic, which is the pre-analytical phase of tumor tissue testing with comprehensive genomic profiling. Specifically, we'll be learning about the utility of microdissection methods to increase the tumor purity prior to testing, and specifically be discussing precision enrichment, which is a proprietary microdissection technology that our lab has developed. At Foundation Medicine, we have a wonderful team of board-certified pathologists who are involved at every single stage of the testing process, from the moment that a sample arrives in the lab to the moment that a personalized report is sent to the ordering clinician. At the time of tissue adequacy assessment, the goal is to determine whether that specimen will require microdissection to increase the tumor purity, which will then increase the sensitivity of the assay to detect actionable genomic alterations. We have two types of microdissection in our toolkit. We have conventional razor blade microdissection, where we can mark up an area of the slide for dissection with a sterile razor blade. But today, we'll actually be discussing a proprietary method that we've developed and validated known as precision enrichment. So this involves using a very tiny 16-gauge needle to do a core needle biopsy, approximately 1 millimeter squared in size, directly from the FFPE block. So this allows us to isolate tumor from surrounding non-neoplastic stroma without facing into the block or consuming any unnecessary tissue. Again, the benefit here is to increase tumor purity and therefore increase the sensitivity of the assay for detecting the genomic alterations that will guide diagnosis and treatment. It also has a wonderful effect of decreasing turnaround time, because it allows us to take specimens that would have been suboptimal or would have failed in a lab that doesn't have the ability to do precision enrichment and convert those into great specimens that will yield actionable results. So then that patient does not have to undergo a repeat biopsy procedure. The fact that we have a precision enrichment in our toolkit actually is one of the reasons why we have the industry-leading quantity not sufficient rate of only 1 to 2%. And we've validated this in a peer-reviewed study in Frontiers in Oncology from 2024, where we showed that implementing precision enrichment in our lab led to a 67% decrease in QNS rates. And furthermore, it enables us to deliver actionable results in specimens that even have as low as 1% tumor nuclei cellularity. This slide shows an example of what the process looks like. So we have a lymphadenectomy specimen here with metastatic carcinoma. A 1 millimeter focus has been targeted for precision enrichment, as shown in the light blue circle. This H&E slide is then aligned with the FFPE block, and that precision core needle biopsy is performed. And then we'll get a post-precision enrichment H&E slide, which shows basically that we are on target and we have achieved exactly where we set out to do the enrichment. You can see here on the right what that biopsy looks like. We'll trim off the excess paraffin, and then that specimen can be leveraged for nucleic acid extraction. So it's a quality controlled process. And what you'll notice here is that because we were able to do precision enrichment on this block, we did not have to put that block onto the microtome and face deeply into it. So this is a wonderful way to practice tissue stewardship to ensure that we're not exhausting or otherwise wasting patients' tumor tissue. As I mentioned, post-testing, our pathologists will do their expert review of all the genomic alterations that were detected in the sample, integrate that with the clinical pathologic and radiological picture, highlight any unusual or critical findings that are important to the patient's diagnosis, and then sign out that final report to guide therapy. This is a case study of a 59-year-old woman with history of breast carcinoma. She presented with recurrent carcinoma involving a lymph node, and a lymphadenectomy specimen was submitted for comprehensive genomic profiling with Foundation 1 CDX. You can see here, looking at low power at the H&E slide, the overall tumor purity is very low, well under the 20% standard needed to perform CGP. But this is where precision enrichment really shines. This is a specimen that could have resulted in a QNS or a fail report, but instead we were able to perform a precision enrichment on the specimen, target a 1 millimeter focus of metastatic carcinoma, and isolate that from the non-neoplastic lymphoid tissue. Thanks to that, we were able to increase the tumor purity from 1% to approximately 50%. And as you can see here on the final report, we identified an actionable PIK3CA mutation that can then be treated with targeted therapy. So you can see here that this case study, and this illustrates the flow of this patient specimen through the lab, really emphasizes the utility of precision enrichment in identifying treatment opportunities for targeted therapy, ensuring that you get a report with very quick turnaround time and for preventing failure and preventing the need to submit additional sample. I'll highlight 3 other real-world examples from our manuscript. We see here a prostate cancer, a colonic adenocarcinoma, and an ovarian serous carcinoma, respectively. And in all 3 instances, the initial tumor nuclei cellularity was well below 20%. We were able to perform precision enrichment for all 3 cases. And in each of these cases, it enabled us to detect actionable genomic alterations. So in the case of the prostate cancer, we found a homozygous deletion of BRCA2. For the colonic adenocarcinoma, we detected microsatellite instability high status. And for the ovarian cancer, a homologous recombination deficiency signature. All 3 of these genomic biomarkers require elevated tumor purity to ensure that they can be detected. And in each case, precision enrichment allowed us to elevate the tumor purity of the samples so that these actionable biomarkers could be reported. This is a wonderful slide that shows our real-world experience with FoundationOne CDX from our manuscript. So you can see in mid-2020, we implemented the ability to perform precision enrichment, and then we established a program that increased the use of precision enrichment in the lab over the subsequent year, as well as the total number of cases going under enrichment in general. And now today, at the mid-2025, up to 50% of samples undergo an enrichment procedure, and that has led to a decrease in QNS rates by an order of magnitude. So now our QNS rates, again, are industry leading at 1 to 2%. So it's really been an incredible impact on the lab, and more important, on patient care. The key takeaways that I want to leave you with today are the learning points is that a tumor tissue specimen that has low tumor nuclei cellularity is going to be at increased risk of testing failure with CGP and at increased risk of false negative results. These are both problems that can be solved with our proprietary precision enrichment technology, which has markedly increased the likelihood of successful genomic profiling on specimens, particularly those with limited tissue or with low tumor purity, even down to 1% tumor purity. And as we showed in the validated peer-reviewed literature, 67% decrease in QNS rates can be achieved by using precision enrichment. And this really is a wonderful benefit to patients because it ensures that their samples can yield actionable results. I wanted to thank you all for your time, for sharing in these exciting updates, and just wanted to reiterate that our team of pathologists is here to support you and your patients with all of your patient care needs. Thank you.